today, when I talk about resuscitation, actually, to be very honest, resuscitation is such an empiric term where we talk about resuscitation, the most important thing comes in. So when we talk about resuscitation, friends, we talk about a procedure of restoring life or trying to restore life. And this is a process where we try to correct the physiological disorders, such as lack of breathing or heartbeat in an acutely ill patient. It is an important part to understand that this will actually encompass various specialties like anesthesiology, trauma surgery, emergency medicine, intensive care, and resuscitation per se is a word called 𝑬𝒑𝒆𝒂𝒓𝒂𝒂𝒕𝒂𝒂𝒂, where it comes from the fact that in anesthesiology, the history goes that a young lady who was drowning in the river Seine was resuscitated by an anesthesiologist, and that reanimatology or resuscitation, that was the process which was defined as reversal of the physiological trespass which is causing death in an individual. Now, the more important thing is that resuscitation as a procedure, as a set of acts that you do to restore physiology is important as a drill, but what is more important is the continuum of the process which has led to that cardiac arrest or cardiopulmonary arrest, and realizing that resuscitation is a continuous process which aims to good neurological restoration. With this background of resuscitation, once more I would like to say that look at the continuous story which has led to the cardiac arrest and then take it further, keeping a close watch on neurological recovery. So this is when we look at the various conditions which can actually lead to a cardiac arrest. If you look on the left hand, hypoperfusion, acid-base imbalance, gas exchange abnormality, what called respiratory failures, altered level of consciousness because of one reason or the other, and lastly, dyselectrolytemia and coagulation abnormalities. All these systems, if you look towards the example on the middle, will cause one of the various forms of shock or major physiological trespass and lead to certain situations which will finally cause to arrest. And when you are coming out of that revival by doing certain set of drills and kind of procedures which are interlinked, which is called as a chain of survival, you don't need to forget the reason where we have started from. So for example, if you have a septic shock patient who had gone into cardiac arrest, the usual CPR drill that we will talk about will also include the source control, the thought process about the antibiotics, getting the fluid resuscitation. And at the same time, if you're talking about a coma, which is because of a drug overdose, you must understand that that baseline is important, which we always call as in simple 5H and 5Ts, but there is far more than that. And this is very important to know the system from where it has started. So if it is a cardiorespiratory compromise, you need to look at hypercapnia, hypoxia. You have to look at the various forms of shock, that is hemorrhagic, cardiogenic, distributive, or obstructive shock. If you're talking about an endocrine disorder, then you need to know the hyperglycemia, hypoglycemia, the hypohyperkalemia, and the coagulation abnormality, especially in cold immersion injuries. And based upon these, when you are going ahead, you need to look at the respective biomarkers in alignment. So for example, for a shock, you need to understand the preload cardiac output, the permeability, look at the Beck's triad for cardiac tamponade, and this will give you an idea where you are coming from on the shock front. While on the ABG abnormalities, the pH, PCO2, PO2, and the bicarbs will give you an idea where we are standing. And lastly, the electrolytes, the absolute measurement of electrolytes if you are dealing with an endocrine disorder. And finally, your treatment will also be accordingly based upon, along with the CPR drill that we will be talking about. So the treatment will vary from IV fluid to inotropic agents to vasopressors to cardiocentesis, chest drains, thrombolysis, acid-base support, interventions and supports depending upon even an RRT, and getting those dyselectrolytemia corrected, and which will be responsible for a complete resuscitation. With this background, when we talk about the act of cardiopulmonary resuscitation, you need to understand that more the number of hands, the better is the outcome. So though we talk about a basic life support where a one person or a single hand rescuer, when we talk about, or one pair of hands, that is a situation where sometimes you're forced to, but in a hospital, majority of the time, we will be talking about a CPR, which is an integrated set of things with multiple disciplinary and a lot of other supports imperatively, either in the purview of out of hospital or in hospital cardiac arrest, where a chain of survival is established based upon your location. So if you look at the American Heart Association chains of survival for in-house, in-hospital cardiac arrest, the most important thing is early recognition and prevention. So please understand that whenever you have spoken about what are the important chain of survival, the most important thing is rapid response team. A code blue, which is activated when the person has turned blue, has a high likelihood of failure unless you have been able to pick up in the twilight zone, where the patient is going through altered behavior, tachycardia, breathing difficulty, hypoxia, but not yet arrested. So early recognition and prevention. Then comes obviously activation of your local emergency response team so that right number of people come with the resources for an early high quality CPR and defibrillation at the earliest. Then you move on to the post cardiac arrest care and recovery. So if you notice, in an out of hospital cardiac arrest, the only sequence change which happens is that you are looking at an activation of emergency response followed by the same steps, but there is an advanced resuscitation which comes in between. So the moment you have a BLS provision, you move on to advanced resuscitation. And that's something which is very, very important to understand. And rest, everything is essentially the same. There is no point doing an early recognition and prevention unless we are talking about educating the population about basic life support. Move on to the adult cardiac arrest algorithm. Now, this is something which all of you go through and you all are well aware. There have been changes in most of these. If you look at American Heart Association in 2020, gave this beautiful algorithm which we need to stick to, which is about starting CPR. So this is the step one, where you give oxygen, attach monitor and defibrillator. Now we will be only restricting to in-hospital cardiac arrests, where when you start CPR, we are assuming that you are immediately activating, and if it is not already activated, you are calling for help, attaching monitor and asking specifically for defibrillator. In the hospital, majority of the time, your crash cart will have a monitor and defibrillator together. Or if your patient is in the ICU or in kind of HDU, there may be a monitoring already going on. So with this background, you need to look at the first important decision, whether the rhythm is shockable or not. And now we must know that of all the shockable rhythms, ventricular fibrillation, pulseless, VT would be the most important rhythms. And the non-shockable rhythm will be distributed as asystole and pulseless electrical activity. So once you have been able to identify whether your rhythm is shockable, that is either it's a VF or it's a VT, which is pulseless VT, the rhythm is going to be into the shockable rhythm. And there you immediately provide with the shock. Now you can always argue that should I wait for the defibrillation or start with the CPR? So go back to step number one. Any unresponsive individual where you are worried that there is no carotid pulse, you have to immediately start CPR while you are searching for the defibrillator and thinking about the shockability of the rhythm. Moving on, you have the shock delivered with minimal interruption of CPR. You continue for 2 more minutes of CPR, continue getting an intravenous or intra-osseous access so that you can continue with the next level of preparation if it is a shock resistant, kind of arrest. So CPR 2 minutes, you again do a rhythm check. And at this point of time, either the rhythm remains shockable or it becomes a non-shockable rhythm. So if it remains a rhythm which is shockable, you again deliver another shock. So this is the second series of shock. You go ahead with CPR and every 2 minutes you do a rhythm check. Continue giving after the second shock epinephrine every 3 to 5 minutes and consider advanced airway with capnography at this point of time. So 2 shocks delivered, the patient is still in a shockable rhythm. You are planning to continue with medication at this point of time, and you have to move on to an advanced airway if it is not already present by this time. And then you keep on doing the same short cycle repeat. That is 2 minutes of CPR, looking for the pulse. So the first thing was shock resistant, then was the drug resistant, then another drug that is codron. And every time you are intervening, If the rhythm is shockable, every 2 minutes you keep giving shocks. So I hope by this time the basic element of a shockable rhythm CPR is clear. Now we just look at what exactly would you do if the rhythm was non-shockable, which means it was either asystole or it was a pulseless electrical activity. Very, very important at this point of time, because if you have a shockable rhythm, you still have some time to start thinking for the cause if you have lost track of it. But if you have asystole or PE, there is no time. You need to really think hard about the reason why the patient has already gone into asystole, because you have to now go back and to look at the system. Is it a cardiac system, respiratory system, endocrine disorder, whether it is a tamponade, whether it is a thrombus, and you keep on asking yourself, because it's not gonna help if in the next 10 minutes you are converting this non-shockable rhythm into a shockable rhythm. I hope everybody is clear with me at this point of time. This is the major difference between a shockable and a non-shockable rhythm CPR. If you have a primary non-shockable rhythm, the story is over if you are not converting into a shockable rhythm and finding out the cause which led to this. Just giving epinephrine will not make a difference, because technically there is an 8 to 10 minute gap between a shockable rhythm converting into a non-shockable rhythm. So you are actually around 8 to 10 minutes late if you are already having an asystole, or if you are having a PEA, probably there is some kind of an extraneous reversible factor which can be taken care so that the rhythm can be restored. Irrespective, when you are not giving a shock, the drug comes first. So if you only look at very closely, you will realize that the only difference between the shockable and non-shockable rhythm is that if the shock is not there, you are already moving on to the epinephrine part high up. So you give epinephrine ASAP, continue CPR, and you have to take an access early on. The advanced airway access comes up early, and the rhythm remains shockable or non-shockable based upon your CPR. If you have a shockable rhythm, then you continue going on the shockable rhythm pathway. If you have a non-shockable rhythm, then you continue looking for the reversible causes.